Hello, hello, and welcome. Thanks everyone for joining us. We're just going to wait for a few more people to jump in.
They're jumping in.
They're jumping in.
They're jumping in.
Give them another minute and then we can get started. Thanks everyone for joining. We're just going to give another 60 seconds for folks to join and then we'll kick off. A very exciting conversation for you all on high demand conversation on menopause and hormones and sleep and how these impact women's lives, which is a very underemphasized topic that we're very excited to have Dr. Kelly Casperson join us for. All right, why don't we kick off? Welcome everyone to another Apollo Neuroscience webinar. I'm your host, Dr. Dave Rabin. I am a board-certified psychiatrist, neuroscientist, entrepreneur, and inventor. And I am the Chief Medical Officer of Apollo Neuroscience. And the Apollo technology was a tool that we developed to improve sleep and calm and feelings of relaxation in people who, in all people, but particularly to help with sleep and stress, and using natural techniques that help us to rely more on ourselves and train us to use more of our own abilities to heal and to be less reliant on drugs, because drugs are useful, but they're not the answer to everything. And we have really worked hard to curate this content for you based on what you have all asked to hear about. And this is a very special webinar that we have a very special guest to talk about menopause, which is something that in many areas of medicine is not well taught and not well taught to doctors and clinicians, but also not well taught to our communities and how we can manage these symptoms and this phase of life more effectively. And so just to set some basic ground rules for today, we have our team here to answer any questions that come through. Please post them in the Q&A chat, the Q&A box, not the chat box. If you want to just say hi, the chat box is great. But if you have questions, please post them in the Q&A box and our team will work to answer them and we'll answer whatever questions we can live. We won't be answering any personal health questions here because we don't know you. So if you have general questions about what we're talking about, we're happy to answer any of those. We also will not be answering live any customer service questions about Apollo or the technology, but we have customer service folks on the webinar. So if you have any questions, please feel free to reach out or reach out directly to our customer service team, and they're happy to help. And again, we won't be covering personal medical questions, but general questions about health, wellness, menopause, or any of the topics that we cover here today are all fair game. And with that, I would love to welcome Dr. Kelly Casperson. Kelly is a urological surgeon, author, sex educator, and top international podcaster whose mission is empowering women to live their best love lives. Dr. Kelly identified the need for better resources and developed a sex education membership that covers topics like sexual health, intimacy, mind work, and the science of desire. Kelly, thank you so much for joining us. I know how busy you are and really appreciate your time.
Thanks for having me. I love neuroscientists, man. I was a neuroscience undergrad. I'm
I
doing
remember
PhD dropout. So anytime I can hang out with Dr. Dave is a good day.
Same. And I remember we talked about that and our shared passion for neuroscience and
Our shared
just
hate
how
for
much it's come
microscopes.
out. Yeah, and our shared hate for microscopes, yeah, that are now not used as much anymore in training. It's all digitized now. Thank
See,
goodness.
I should have just hung in there.
Right. I know, right? Um, well, is there anything else that you'd like to, before we jump into questions, is there anything else you'd like to tell the audience about you or your background or what led you into this space
Yeah.
of the
So,
study?
so for people who don't know what a urologist is a surgical subspecialist who specializes in surgery of the kidneys, external genitalia, bladder, prostate, you know, vaginal prolapse, bladder leakage, kind of the genital urinary system of the world. And so my interest is kind of unique because urologists are very we invented Viagra, right? So we're very comfortable with the male sexual function. And I had a patient change my life, therefore changing the people that I reach now lives, because she had female sexual dysfunction and I didn't know how to help her. And so really that was about 5 years ago. I dug deep into female sexual health. And so I always joke, sex got me into hormones because everybody said, well, you know what happens with menopause in your sex life? And I'm like, no, but I'm staring down the barrel at it. I should probably learn, right? So really diving deep then into hormones and why hormones are helpful, why we're still so afraid, really kind of evidence-based, because I truly believe that women can make great decisions about their health. They just simply need the right education and information. So that's how a urologist got into sex med and hormones.
That's great for people to understand, and I think a lot of people don't know where these discoveries came from, and why Viagra, which is a male sexual enhancement tool, came out of a mostly male urological specialty of studying the male sexual anatomy and urinary tract, and we don't have a lot of tools for women sexual arousal, for improving intimacy, for any of the kinds of things that we have for men. We often don't have them for women, and women have arguably much more complex cycles of life with respect to hormone changes. There's a monthly cycle, of course, that we've talked about with Stephanie Estima, the menstrual cycle, where there's 4 major phases that the woman's body goes through for what we call the main reproductive phase of life. And then there's as we exit from the reproductive phase of life, right, we enter into the premenopausal, perimenopausal, postmenopausal phase of life, where all of those hormonal changes we got used to during our lives now switch completely into a totally different situation and a different balance. And that has a huge impact on our energy levels, our mood, our sleep, and just the way that we feel on a day-to-day basis and what we're able to do. And I'd be curious to start with, maybe could you just give us a little intro on what's happening during as a woman transfers from this reproductive phase of her life into a perimenopausal or a menopausal phase of her life, and then what happens to the hormones during these phases as a woman goes through menopause?
Yeah, happy to talk about it. And I always want to, I think whenever people say that women are complex, it was when I got trained in medical school, saying a woman was too complex to figure out was a very good way of dismissing her, right? Like, too complicated, sorry. And I think of it now, like, not to be crude, but dudes are like Honda Civics, right? They're trusty,
Yeah.
they're reliable, they're going to get you somewhere. It's a Honda, right? Women's bodies are freaking Ferraris. Like, these are like finely tuned, very, very advanced machines. They can do way more than a Honda Civic can do. But we've studied Hondas our entire life, right? And so it's really like, no, this is a finely tuned machine that can create life. Like, it is a miracle. We're lucky that we have Ferraris in this world, right?
Yeah.
So I always
and
like
Lamborghinis.
and Lamborghinis, yes. So it's like, I always like to spin it of like, we're not complex like it's an insult and dismissive. We're complex like finely tuned, highly refined pieces of machinery, if in our world that we call humans machines. But
highest, like, probably like the highest performing thing, highest performing
create
thing
life,
that we
man.
could ever have, right? Women can create life. This is no joke. One of the most miraculous things.
It's miraculous. Yeah. So I always like to put the positive spin on it of like, we create the world. Like, it's
Right.
amazing. But we need to learn about what happens, right? So we can only create for a couple of decades, right? Start having your period maybe around age 15, average age of menopause, 51 in America. Average age means 50% of people are going to go through menopause after 51, 50% will go through before 51, which is important to know when you go to your doctor and your doctor might dismiss you and say, you're too young. Like, well, average age is 51. This doesn't mean it happens for everybody. Menopause defined is the end of the monthly cycle. It's defined by a physician about 200 years ago. 200 years ago, we didn't have hysterectomies, we didn't have IUDs, we didn't have uterine ablations. So when your periods stop is actually kind of a crappy measure because there's tons of people where we've already stopped their periods, right?
Right. There's no hormonal birth control back then either.
And there's no
So,
hormonal birth control. Yeah, that's 4 things. So it's kind of a crappy measure now because, well, yeah, back in the 1800s, if you lived long enough to not have periods, that was menopause. But you don't know now because for all those reasons, right? But the other problem with defining menopause as the end of periods or the end of fertility is that's actually just a sign or a symptom of what's going on. That's not what the thing is. That's just one of the consequences of the thing. And the
right.
thing being a profound change in the production of hormones, primarily from your ovaries. So ovaries make testosterone and androgens. Hard pause for people to swallow that we have tons of testosterone in our bodies. From the androgens, we make estrogens, right? And the ovary right now, because of science research or life in general, has a lifespan. And humans now are outliving the lifespan of their ovaries. So that truly, if you want to have a better definition, is what's happening. The fact that your periods end and you no longer have eggs and can create babies is one of the things that happens from what is actually happening, which is the end of the ovary's functional lifespan. Ovary will still make some hormones, but not on the level of your 20s and your 30s. So that's when people say, well, how come your ends of your periods make your hormones? No. That's just one of the things in this constellation of the hormones changing. But it's not something you can see, right? You can
Right.
see your period stopping pretty clearly, but you can't see the decreased production of hormones. And that's when we talk about what's happening in midlife, the decrease in hormones is what's happening. Not many people know that. And the other, just to add on perimenopause a little bit more to this, it's not like a nice, smooth, slow airplane landing onto the tarmac. It's like literally a hot air balloon in a tornado, right? It's like up, down, down for a while, then up. So it's a lot of people will call it reverse puberty because the ovary's trying to keep going. The brain starts sending signals to try to kick the ovary to keep going, right? So it's kind of this back and forth, up and down for a while. So it's not like, and then on your 51st birthday, there were no hormones, right? Like, it's not like a clean door shutting. It's more of a very, very bumpy end to the production. So
Yeah.
hopefully that cleared it up for some people.
Yeah. Yeah. No, that's really helpful. And I think a couple things you mentioned I want to double click on. Number one is that the average age of menopause in women is 51. So many women spend their mid to late 30s and early 40s concerned about entering menopause prematurely because they start to have changes in their cycle. And that is not necessarily an indication that you're entering menopause early. It's often a lot of these studies that were conducted, like the ones you mentioned from 200 years ago, before we had electricity, showed that, because of many things that were different in the environment, that women did have less ability to have children earlier in life, but we also didn't have electricity and we also didn't have hand washing, right?
Yes.
So
or
hand
consistent food.
Or consistent food, right? And hand washing as a tool to, that was which is thought to be one of the most greatest discoveries in all of Western medicine next to antibiotics, didn't even get integrated into like the 1900s, 1910s. So there were a lot of great changes that happened between when we originally characterized the patterns of the female body when we called it complex as in confusing versus now we understand complex is beautiful and powerful, right?
Yeah.
And so I think that is really interesting. We need to constantly remember to update our definitions and our descriptions of these things as we, become more well versed in our understanding of the human body, but especially the female body, because we didn't have a lot of research up until the last probably 30, 40 years into this area, that we know a lot more now. And just because you're having some irregularity in your cycles, in your late 30s, early 40s, does not mean you are rapidly entering menopause. It could, but chances are it probably means there's other things in your life that are impacting that, right?
Yeah, I mean, even early perimenopause, and remember, there's no blood test. You can't go to your doctor and say, "Can you check me for perimenopause?" Right? It's a clinical diagnosis based upon signs and symptoms, and there's no blood work, X-ray. There's nothing you can do to say that you're in it or not. It's like if you're of a certain age and you're having certain symptoms, and they've ruled out other diseases and conditions that can be it, you're like, this is probably perimenopause. So they've broken perimenopause into like several different phases. The later phase being more spaced out periods. About 20% of women will have much heavier periods, again, because of that higher estrogen that tends to happen, lower progesterone that tends to happen. But in the beginning perimenopause, periods are regular. At least that's, how the scientists are kind of breaking perimenopause into the sections. So just to reinforce what you said, just following your period, although quite helpful, won't tell you everything.
And so going back to the hormonal changes that happen, I think this is one of the things that's very confusing for women, because you said the ovaries produce testosterone and androgens, and then a good percentage of those get converted into estrogens, right? And then some of that happens in the ovaries, some of that probably happens in the fat, right? There's different parts of the body that make estrogen. But women's bodies tend to be, at most phases of their menstrual cycle, more estrogen dominant overall, unless I'm getting this wrong. I'm trying to remember from my medical school and gynecology training days. So what I remember is that estrogen is dominant in the woman's body during most of the reproductive phase, where reproduction is possible. But then as women start to get into perimenopause, that gradually the estrogen starts to taper down in dominance, and then testosterone starts to become more dominant as a hormone in the woman's body. Is that still our understanding?
Not fully. So we'll start with testosterone first. So we have 3 to 4 times more testosterone in our bodies than estrogen in our, let's call it our 20s and 30s, right? We're not in this perimenopause stuff.
Right.
We don't know that because they're measured in different nanograms per deciliter versus picograms per milliliter, right? But so testosterone's the dominant one. We just gendered these hormones and said testosterone's for men, estrogen's for women, and we made it not exist in these bodies. So testosterone's what we have the most of. Doesn't mean I wouldn't use the word dominant for that. It's just what we have the most of.
Even in our reproductive phase, even in women's reproductive phase.
Especially in our reproductive phase.
Fascinating.
And then between the ages of 20 and 40, we lose about 50% of our testosterone. So testosterone starts going down much, much earlier, regular periods, but the testosterone is already going down. What's the significance of that? We don't know. We hardly know that testosterone's in female bodies, right? We got to do a lot more research. Where I think people will get that kind of, air quote, testosterone dominant is your periods are done, your estrogen and progesterone are low, you're still making some testosterone. Ovaries will keep making some. So you might see more androgenic things like, facial hair where you don't want it, stuff like that, male pattern balding, because there is still a little bit of testosterone. But it's still not a lot of testosterone. And then in perimenopause, so reverse roller coaster, you can actually get very high estrogen because the brain's trying to keep the ovaries going, and really low progesterone. And certainly sleep issues start kicking in here. But the problem with my problem with labeling anybody as dominant, and somebody, how people will latch on, right? They'll be like, I'm estrogen dominant.
Right.
Well, on Tuesday. Right? Like not next month. Right. So I hate the labels, because women will take them as like the identity and not realize that this is a forever fluid changing environment.
Yeah, I love the way you put that. And I think that's really important, is to always remember to be careful with the way we label ourselves, because we're not the same one day to the next, especially women. The Honda Civics tend to be more similar
Honda
day to
Civics
day.
tend to Honda.
They tend to, right, they tend to chug along, right? But women's bodies are changing every single day. The hormonal milieu is shifting and cycling all the time. And so I think your point is really well taken, in that there are, the body is changing all the time. And so not to cling to labels of being, one hormonal phase or another, or dominant or not dominant in one area, is really important, because it reminds us to, appreciate the change and adapting to the change that's happening all the time. And I think one of the things, since you mentioned it, that a lot of women talk about, especially coming into perimenopause and menopause, is sleep. And that sleep changes, and it's sometimes harder to fall asleep, harder to stay asleep, harder to get good, deep, restful sleep. And there may be hormonal reasons for this, but there might be a lot of other reasons for this too. And I'm curious to hear what do you think is going on in sleep during these phases?
Well, I mean, the first thing is just to acknowledge how incredibly common it is, right? So they say about up to 80% of people will have issues with sleep in midlife. And it's different for everybody. Some people will fall asleep perfectly fine. They just can't stay asleep. So they have early morning awakening. Some people, it takes them longer to fall asleep. And the first thing, that everybody's going to talk about is sleep hygiene. So dark, cool room, get off of the screens. Screens are very arousing for the brain. Reading a paper book. Some people will say Kindles and stuff that look like paper are a little bit better because they don't have the bright lights. But like, to really calm the brain down before sleep, avoidance of alcohol. People will use alcohol because it's sedating, but it causes waking later on in the sleep cycle. So avoiding
and reduce deep and REM sleep too.
Yes. Caffeine, right? I'm in the Pacific Northwest, so it's like we just like to drink it all day long here. But caffeine's half-life is 8 hours, right? So 8 hours after a cup of coffee, you still have 50% the amount of caffeine in there. I wish it wasn't true. But so really kind of maybe pushing earlier the caffeine dose for people. So that's the behavioral therapies. But the hormonal changes, there's two big players.
That's for everyone.
That's for everybody.
You're including men and women.
Yeah.
First. Okay.
Yeah. So how estrogen helps sleep is it really works on temperature regulation really well. So if you're waking up because of a hot flash, night sweats are basically hot flashes at night. But if you're waking up because your temperature regulation, the estrogen can really help that, decreasing the hot flashes, night sweats. When you're on properly dosed estrogen, the hot sweats, night sweats should be improved by about 80%. There is no drug better than estrogen for treating hot flashes. And we might want to just get into, is estrogen safe? Because I know a lot of people need to start there. But then really talking quick about progesterone. Progesterone is the kind of gets the label of the sleepy hormone because it works on the GABA receptors in our brain. It's basically God's benzodiazepine. So it works on the GABA receptors, causes sedation, which is great because we dose it at night. You get sleep, and it's a short half-life, short-acting micronized progesterone. So it's usually gone by the time your day starts the next day.
And maybe that's really helpful because I actually did not learn that about the role of how estrogen progesterone supplementation can improve sleep. I knew about what happens in the woman's experience as those hormonal levels start to change, but we can also now supplement with estrogen and progesterone in different ways to help improve a woman's experience in these phases. Can you talk a little bit about and maybe this is a good segue into, is estrogen and progesterone, or are estrogen and progesterone supplementation safe? And maybe what are the best ways for women to learn about it, or what are the best formulations? Is it oral? Is it transvaginal? Topical? What are the patches? What are the best ways for women to start to learn about this stuff?
So we've been able to give people medications, hormones, for many decades. We've been giving people estrogen, testosterone, progesterone for many decades. But in the beginning, these were synthetic formulations. And a synthetic formulation is still what birth control is. Many wonderful things about birth control, not dissing it. I just want people to kind of start learning the difference between a hormone that your body makes and then us being able to actually make that exact same hormone just to give it back. Insulin is an example. Thyroid is an example. So lots of things that are exactly like what your body makes. Testosterone, we give that to men, we give testosterone to women. Exactly what your body makes, we're just giving it back. What that is called is, in America, we call that bioidentical. And we have many FDA-approved products that your insurance covers that are bioidentical. What that means is it's exactly what your body made. We're just giving you back some of it because your body makes less of it now.
Right.
So the bioidentical, body identical, in the UK, body similar, right? There's many different ways of saying it's exactly what you made. We're just giving you some of it back. Those are the safest hormonal formulations. Now, there are nuances and niches. That's why you see a specialist if something doesn't work for you. There's always asterisks to all of this. But by and large, what your body makes, giving it back to you in physiologic doses is incredibly safe. The biggest fear, just to knock it out of the ballpark now, in 2002, the Women's Health Initiative came out, and basically the media went nuts. And about 70% of women were ripped off their hormones in this country because they said giving a woman hormones causes breast cancer. We now know that that was not true. That was a synthetic progesterone was kind of the biggest player on that, and the placebo arm was contaminated. So anybody who does research knows if you're comparing something to placebo, it matters, number one, if they were randomized for the thing you're looking at, which they weren't randomized for breast cancer risk. And then number two, the placebo arm was artificially had a low risk of breast cancer. Interestingly, because those placebo arms used to be on estrogen. And now we know estrogen actually decreases your risk for breast cancer. So not only do we say it's safe, we're actually saying like estrogen actually is breast protective. So it's a fascinating conversation. And if people want to hear more, I would direct them to my podcast because I do a lot of time talking about breast cancer, health, hormones, debunking the myths of hormones. Because I think the fear of not wanting to cause harm prevents a lot of women from getting the help that they need. And one of those being sleep. We know if you don't sleep, it's not good for performance. It's not good for your lifespan.
Right.
But
Yeah,
you don't want to take anything that you think's going to kill you, rightfully so.
Right. Yeah, and I get this all the time. You know, I think I have a lot of women who come to my practice as well who are struggling with the psychological, mental, emotional components of menopause and or perimenopause, and they're really struggling, and they don't want to take estrogen supplementation or hormonal supplementation because somebody told them or they read somewhere 20 years ago, right, that there is a increased risk of breast cancer or of another cancer. And I think this is why it's so important that we're having these conversations now, because a lot of those studies that were done had some truth to them, but were also not necessarily conducted in the highest level of scientific rigor. And so we have to go back and do more studies and reevaluate. And as you said, you know, now we know that especially if you're somebody who doesn't have breast cancer, then and you're going through these phases of life, that estrogen can be natural levels of bioidentical estrogen supplementation can actually be preventative and protective, which is really exciting. And it also helps to manage a lot of the symptoms that we were talking about.
Yeah. Yeah. I mean, if you look at mood changes, but you have a 40% increased risk of depression compared to the premenopausal people. Perimenopause is, and then that'll mellow out with age. It's the perimenopause with the mood changes, not because so much of what the level is, but it's the changes. The brain's incredibly sensitive to the changes in the hormones, which is why the transition
piece,
the ups and downs, the ups and downs.
Yeah.
So you see more, you know, migraine issues because of changes in hormones and mood, anxiety. 25% of women in this country are on an SSRI in midlife. A lot of them are on that to treat perimenopause and menopause symptoms.
Wow.
Yeah. And so to me, I'm like, we're treating it with the wrong thing. We can simply give our hormones back and not get the side effects of SSRIs, right? And actually help them a heck of a lot better than the SSRIs. The SSRIs are not bad at hot flashes, night sweats, but they're not good.
Right. It's more like a band-aid, right? Like it's not actually, it's not getting to the root of the problem,
It's
which
not
is
treating the root cause. Yeah, that's
right,
right.
which is this hormone imbalance. It's or the transit hormone transition. It's really just kind of numbing people to the negative feelings of the depression or the mood lability, shrinking your what we call like shrinking your emotional window, so you're not as perceptive of negative experiences, but you still have the hormone imbalance that's causing the problem in the first place, and that's not taking care of it.
Yeah. For an example, I saw her for bladder leakage. So I wasn't really even specifically seeing her for hormones. Ended up putting her on estrogen and saw her back. And I'm like, oh, hey, how's that estrogen going? How's it? And she looks at me and she goes, you fixed my rage. And this is like
Wow.
salt of the earth person. She's like, has several kids, just a beautiful, wonderful person. And she's like, I wasn't an angry person. And then I was. And now that's better. And it's like the profound quality of life that can happen just by giving your body back what it always had is life changing.
Yeah. Actually, now that you're talking about that, maybe I need a little more estrogen in my life. Let's fix
somebody,
that rage.
somebody made me this piece of art, this beautiful piece of art. And it's like, I thought I was angry. Turns out I just needed an estrogen patch. But I mean, when you gender hormones and then you call them sex hormones, right? These are called sex hormones.
Right.
You
A lot of
erase the
labels.
possibility of them working in the brain. They
Right.
modulate neurotransmitters, right? Dopamine, GABA, serotonin, like they're modulators of brain neurotransmitters.
Yeah, exactly. And
What
I think you
neuroscientist doesn't love that?
yeah, no, it's incredible. They're master modulators, right? They're not
Yeah.
just modulators, they are these hormones that we're talking about, testosterone, estrogen, progesterone, have downstream effects that impact the entire functioning of our brain and body. So they regulate multiple different systems at the same time. Whereas other neurotransmitters we talk about regulate maybe one system here or there at any time. But these are master regulators, right?
Yeah.
They have a huge, tremendous effect. And I think your point is well taken about labeling and not again like not even labeling these with a gender bias, because if you call testosterone the male hormone and estrogen the female hormone, but maybe some men need a little more estrogen and maybe some women need a little more testosterone or vice versa, then we basically eliminate those tools by with the labels, because people become stigmatized for one gender versus another, where it's really just they're just hormones and we all have both of them, and
Yep.
we all have different levels that we need. And it brings up this really interesting concept that I think we don't talk about enough, but we talk about placebo, which you brought up earlier, which is really placebo means the likelihood that you will get an effect from something just by believing that it works, right? So we call that actually the belief effect. So placebo is belief that something will work, increases its chances of working. And for hormonal therapies, mental health therapies, this has a 30% or so increase in your effectiveness of your medications or treatment. So if you believe your treatment's going to work, then it works that much better 30% of the time. And if you don't believe your treatment's going to work because it has a gender label, for instance, like estrogen, and you're a man, if you don't believe your treatment's going to work, even for a mental health treatment, it actually is even stronger of an effect. So it's between 30 and 50% of our treatments work worse when we are, they work 30% to 50% less of the time do they work when we don't believe that they're going to work.
Yeah.
And so the power of the mind is undeniable, right?
I
We
love
have
it.
to be aligned with our treatment goals mentally and emotionally to actually make sure we get the best outcome.
Yeah. 100%. And I think we're completely in our infancy as far as understanding that. And I hope I stay alive long enough for us to figure that out more, because it's fascinating. Just a quick example of hormones being in all bodies. The main hormone we think for sexual desire in men is estrogen. Very beautiful study done, published in the New England Journal of Medicine. They basically blocked a man's conversion of testosterone to estrogen. His sexual desire went down. Normal testosterone, low estrogen, man's sexual desire goes down. In women, estrogen helps desire 100% without a doubt, but testosterone is a very important hormone for sexual desire in women. So the fact that we gendered these, and by the way, where does libido come from? That's the brain. It's a mood. So these are hormones that affect our moods, right? So it's the conversation's so much more big and wonderful than we've kind of put these things in boxes.
Oh yeah, it's absolutely fascinating. And we have, you know, as you said, we're in our infancy here, so we have so much more to learn. And this is just an incredibly fascinating area, particularly because intimacy and sexuality are one of the single most important sources of pleasure for all human beings. And pleasure is in and of itself healing.
Mm-hmm.
Pleasure is soothing to the body. It reminds us that we're safe, and it actually facilitates healing in the body. And so the more that we can destigmatize and demystify some of these experiences for people, ideally, the closer we can get to each other, which means that we're having more pleasure and more healing in our lives. So
Love that.
I think this could not be more of an important area to study. And you know, going back to some of these hormonal shifts that happen, we talked about sleep, and sleep is directly related to energy, and mood, and all of these, you know, we've touched on, are impacted by hormonal levels and the changes that happen in menopause. And could you talk a little bit about how energy and mood also get impacted a little more during perimenopause and menopause?
Yeah. Well, fatigue, muscle aches and pains. Muscle aches and pains is not a complete. Hormones play a huge role in muscle aches and pains. You know, if your body doesn't feel good, your energy is low, right? You don't want to get off the couch. And it kind of, a body in motion stays in motion, a body in rest stays at rest, right? And the role of sleep in healing, repairing insulin resistance, right? Like sleep is so profoundly important for having your day go well that I had a woman, she hadn't slept in 2 or 3 years and was spending upwards of $200 a month on sleep supplements, trying to get to sleep. She came to see me, started her on some very low dose, safe hormones. And I saw her and I'm like, how long? She was sleeping. And I'm like, how long did it take for you to sleep after you started hormones? Because sometimes it can take a while, right? She said, day 3, I slept. You're like, this can be absolutely profound. And like, she was desperately, and the thing, if you don't sleep, then you can develop sleep anxiety, right?
Yeah.
And so you get this in perpetual, like, now I'm stressed about sleep. Now I'm worried about sleep. I'm anxious about sleep. So it can kind of make it actually worse than
Yeah.
if you can just get some freaking rest.
Yeah, absolutely. That's the biggest part about sleep I talk about, is just people, even I've had this thought process before. I think it's almost universal to human nature, but eventually when you aren't sleeping as well as you like for a long enough period of time, you start to ask yourself the question of, is there something possibly wrong with me that I can't sleep and everybody else seems like they can? But guess what? There's nothing wrong with you, because none of us can sleep. 80% of people are reporting that they are struggling with getting to sleep or staying asleep at night right now in the United States, which is an astounding number. And
Huge.
something like 40% of Americans meet criteria for insomnia. And this is not because we don't have the ability to sleep. It's because we do have the ability to sleep, because we're all born with the ability to
Right.
sleep, and to sleep a third of our lives, but we weren't necessarily taught how to access that state all the time as much as possible. And a lot of it starts with just knowing that we're capable of it, which creates safety states in the body around sleep. So we have to
Yes.
believe, right? Like the placebo effect, the belief effect in this role is not believing that you can't, but knowing that we all evolved to sleep a third of our lives, and there's only 2 families in the whole world that actually genetically have a mutation that results in them not being able to sleep. For all the other 99.9% of us, we all can sleep. So creating the safe space inside our minds and in our knowledge of that we can, and then setting up that sleep hygiene environment that you talked about earlier, where you're decreasing screens, you're decreasing stimulation, less caffeine, no alcohol before bed, and just kind of really taking care of yourself and creating a soothing environment helps you to sleep better, which then dramatically impacts your mood and energy the next day.
Mm-hmm. Yeah, absolutely. And I think that's, what that people recommend cognitive behavioral therapy for sleep, is to teach them all of that.
Exactly. Yeah, and that's the whole focus of of cognitive behavioral therapy for insomnia.
Mhm.
When since we're talking about this, we've talked a lot about hormones, which I think is really important. And before we wrap the hormones piece, that we had a good question about, well, I think there are two questions, one of which was, do the levels of hormones supplementation that women have to take change between perimenopause and menopause? And then the second question is, what are the best ways for women to start getting information or access to hormonal supplementation, and also method of administration? Are there any recommended methods of administration for estrogen or progesterone?
Mhm.
Because a lot of women are concerned about taking systemic hormones, and maybe
Mhm.
that's not a concern. But now there's a lot of move towards topical patches, transvaginal applications, and things like that.
Yep. Really, really good questions. You have smart people. Anybody who wants to listen to a neuroscientist has got smart questions. So, yes, the first question being, do doses change between a perimenopause and then a menopause? Not always. I wouldn't say it's standard of like, oh, you got to go down now that you're 53. Like, there's no hard fast. But in general, perimenopausal people tend to do better with higher levels of hormone supplementation. They've got more receptors upregulated. They're already used to kind of performing at that higher level. Whereas somebody, let's say a woman comes to see me, she's 5 years post menopause, right? She's still got symptoms. She just hasn't had a period in 5 years. I'm not going to start her at a high of a dose, possibly. I might start her down much lower because she's got less receptors upregulated. She hasn't seen any hormones for 5 years, right? And she might do perfectly fine at a very low dose. Which brings us to an important point. One size does not fit all. We are not cookie cutters. We are not Hondas, right? Like, everybody is going to need a different dose that's going to meet their needs as far as symptom relief. And that said, we've got great options that when people come to me and they're like, hormones didn't work for me, I tend to not believe that at face value. I tend to say the hormones you were trying weren't the right formulation or they weren't the right dose. So I
Right.
truly believe like a little bit of whatever form of hormone can work for everybody. I'm an eternal optimist. I'm like, your body literally grew up with these hormones. These are not foreign objects, right? So when people say they didn't work, I'm like, you're either dose was off, route was off, whatever, something what you just didn't. Because a lot of people are like, they try it once and they're like, it didn't work. It's like, we're trying to tune a wonderfully complex engine here, right? Like, it does take some, going back and forth and trying different doses, which is very hard in our modern medical world of 10 minutes once a year, right? Like, without a doubt, we are not set up to dial women's hormones in our current medical state. So it is a challenge that you do have to advocate for yourself. Next question was route. So let's break down the two main words talked about for route, usually in regards to estrogen, but not always. Systemic, meaning your whole body. I'm dosing something that's at a high enough dose that my whole body's going to get it. And then the other one, which we call pelvic or vaginal. So it's a cream, a ring, or a pill that we just put in our vagina. And that is local hormones. So local hormones help vaginal health, sexual health, bladder health, recurrent urinary tract infections. Local hormones, really great. They will not help you with sleep. They will not protect your bones. They will not protect your brain. They will not protect your heart. They will not help your mood, right? Because they're not going in your body. They're staying local. Now, the difference is the dosing. That's about what they say is a year's worth of vaginal estrogen is equivalent to one estrogen pill. One estrogen pill, this is hormone replacement doses. One estrogen pill is about 20 times less than one birth control pill. So we just put everything in perspective of this is not a lot of medicine, people. This is teeny, teeny, tiny doses of things. And sometimes that's all our body needs to be optimized.
Yeah, usually.
But when you say,
the body's so sensitive.
At one point or another, about 80% of females have been on birth control. That's this dose. Hormone replacement therapy, vaginal estrogen. Just people don't get that perspective.
Yeah, I definitely did not get that perspective. That is really helpful. And I think the next the next follow-up question to that briefly is, what about postmenopause? So as women are have been on hormone replacement therapy and are coming out of menopause or entering into, I guess, postmenopausal
Postmenopause,
phase.
yeah.
Yeah, does that change? I assume their dose would start to change a little bit based on the new hormonal milieu of the body, or is it just kind of
Yeah, I mean,
testing and retesting to
so
understand what's
yeah,
going on?
first of all, is like these doses are still really low compared to like what you were operating at in your 20s and 30s, right? So it's certainly if you're having side effects, we can back off. But a lot of women, they're like, I'm perfectly happy. And they're like, do I want to go down? It's like, try a lower dose, see if you have symptoms come back. This is the data we don't have. What's your optimal level for bone health, which is going to be different than your optimal level for brain health, which is going to be different than your optimal level for cardiac health, right? We know and we do have this in male studies of a certain testosterone is good for libido, but it's not great for, muscle building, right? Like every organ's going to have their optimal hormone level. Sometimes this is too overwhelming for people because like, I just want to know the dose of like, we don't have those studies because people say, what's the dose for brain? It might be very different than the dose for bone. We know we get bone protection at really low estrogen levels. But as far as what's the optimal for every single organ system, we don't know.
Yeah,
We
we're still
don't we don't
figuring
have
it
that
out.
data.
Yeah, we're still figuring it out.
We're still figuring that out. Yeah.
Yeah. But I think we're on the right track, which is good considering what I'm learning from you and what I've been hearing, at least for doing more studies now, and we're starting to figure it out.
Yeah, I mean, the
But
more people that are taking hormones, then you can be like, they were on this dose, they were on this dose, this is how many heart attacks they had, right?
right.
Like the more people, but right now we have about 4 to 5% of Americans on hormones. The UK is ahead of us for several reasons. Number one, their cost of hormone replacement therapy per person, they've made it less than like $60 a year.
Wow.
Because the UK knows they've got a nationalized health service. They
Right.
know this is preventative medicine. They know they're going to see less downstream health effects. So to them, this is a cost-effective, one of the most cost-effective medicines that exists is hormone replacement therapy.
Yeah.
They also know that women are leaving the workforce because of untreated perimenopause. Big, big dollars. So
Yeah.
they know, let's keep women in the workforce. We got to keep their hormones cheap enough for them to be able to afford them.
Yeah, that
That
makes
was my
sense.
tangent on something. That was my tangent on dosing. The other
No, that
important
was
thing to
great.
know is you don't have to stop your hormones. That's a big myth out there. Like so many women, they're like, my doctor just told me I was old enough. And I'm telling you, like they come and see me for their urology problems 6 months after they've stopped their hormones because your body will change when the hormones stop.
Mm-hmm.
And so it's a myth. There is no age at which you must stop hormones.
That's really good to know. There are certain conditions though, like if you happen to have like a estrogen sensitive breast cancer or cancer or something like that, at that point, you would
Yep.
definitely not want to be taking estrogen supplementation.
Yep.
You should consult your
For your
physician.
course of treatment, the
Right.
the world is changing. So we have about 5 million breast cancer survivors in this country now. Number one killer, if you're diagnosed with prostate cancer, your number one killer is heart disease. If you're diagnosed with breast cancer, your number one killer is heart disease.
Wow.
We are curing cancer enough that you're dying of what other people are dying of. And the whole point of this is we are actively looking at what women it's safe to go on hormones after treatment, not during treatment. You got to get treated for your cancer. But if you're profoundly suffering afterwards, more and more women are being allowed to be on hormones.
Wow.
Just like men,
That's really,
we treat their prostate
yeah.
cancer and then we let them take testosterone.
Yeah. That's like great news.
It's great news. Yeah,
Great
yeah.
news for humanity.
It's great news.
Um,
That's not standard medicine 101 right now, though. That's like what's actively being looked at.
right.
Yeah.
Right. Yeah, that's really fascinating. And it's amazing that we're able to do so much more for people, to the point for cancer treatment where they're able to live out their lives and eventually not, and for the most part, not pass of cancer, which is incredible.
Yeah.
And then, just to follow up on the last two questions, because I think these are pretty quick ones, with respect to postmenopausal women who have never experienced hormonal therapy, is there still an opportunity for them to benefit from hormonal replacement?
Yeah, it's a great question. So the single most popular podcast episode on my podcast is it's a while back now. It's called "The Boomers Should Be Pissed." And the reason I named it that is because the Women's Health Initiative came out. We've had 20 years of women not on hormones, and that's the boomer population. And so because of the WHI, they said the older women did worse. So because of that, kind of the blanket came down and said, old women can't start on it. What are we defining as old? We're defining 10 years post last menstrual period or age less than 60. So it was a hard stop, and they're like, sorry, can't start them then, too dangerous. That's not actually what the data says. Transdermal is best. If you swallow an estrogen pill, it's going through your liver. That will increase clotting factors. That's where you get the increased risk of clot stroke from. Transdermal, no first pass metabolism. Goes straight into the bloodstream, no increased clot risk.
So better through the skin.
Better through the skin. So if you're greater than 10 years post or age greater than 60 and you want to start, lowest dose transdermal is best. And I always say, get worked up. See what your cardiac risk is. Some people will use the cardiac risk calculator and say if it's greater than 10% risk, that person might not be best benefited. But I put women in their 70s on hormones a lot now. And the other caveat, vaginal, so just the localized, any age at any time can start that. I've got people starting their 84-year-old mothers on it because recurrent urinary tract infections kill people. And if there was a drug that decreased urinary tract infections by 50%, we would all want to be on that. And it's called vaginal estrogen.
That's really, really cool. I mean, that's just so amazing that this hormone has so many benefits for the body.
It's how our body existed, right? It only makes sense that our body does better on it. It's kind of like insulin. It's amazing insulin, so life-saving.
Right. Yeah. Well, I think it's just, insulin has like a more immediate effect. If you have too much or too little, you could die within a week or less.
Yeah.
But with estrogen, people have lived for so long estrogen depleted, right?
Yep.
And I think that is the part where we're now, we're starting to see how incredibly important it is to make sure we're actually managing this more effectively, and that by replacing it, we're not just extending the quality of women's lives in terms of sexuality, intimacy, mood, sleep, energy, but we're also reducing their all-cause mortality as a rate of chances of getting things like UTIs in older life, which do actually result in confusion, severe illness, kidney infections, and death for people. So this is a real thing,
More people are hospitalized in the United States of America. More people are hospitalized every year for hip fracture than heart attack and stroke combined. It's just silent because the 80-year-olds aren't out there saying like hip fractures are horrible, right? There's no parade for hip fractures happening.
Right.
But it's like, I think our generation is looking at our parents and we're starting to ask the question, in the world of lengthened lifespan, is frailty inevitable? And if you think frailty is not inevitable, you better start thinking about what the role of hormones on that in decreasing the risk of hip fracture, heart disease, dementia, and quality of life stuff. UTI is frozen shoulder, right?
Yeah.
So your sex life. So everybody's got a different why. And I really think it should be individualized. And the first step is really erasing that fear that was Nothing will control a woman more than making her afraid. And what better way to make a woman afraid than telling her that something her body naturally makes is trying to kill her?
That couldn't be more true. And that's a really important point. And since you mentioned being afraid, and we have about 5 minutes left, I want to end on safety. because that is the antidote to fear, and reminding us that we're safe in our own bodies couldn't be more important. And, Apollo is a tool that we developed to help with that for people. And most of our users are actually women, which I found really interesting because women are more likely to do something about their stress and sleep rather than just to suck it up and move on. They actually do things more often to feel better, which is really important because they know that impacts them, and then how they feel impacts everyone around them. And so, Apollo has been a huge help for women across the board in all these different phases of life. But could you talk a little bit about how a tool like this might be useful in perimenopause and menopause?
Yeah, I mean, to me, I'm like, every time we talk, I'm like, you need to do a study on this. You need to do a study on this. I'm like, the rate of what I'm noticing and coming up is the rate of ADHD in perimenopause. Whether you've always had it and it's exacerbated now, or maybe you've never had it and now you're like, oh my gosh, what is happening? Like, this kind of late or
Yeah,
adult life ADHD. The role of estrogen in anti-inflammatory in the brain, in calming the brain, in again, being the overlord of the neurotransmitters, right? And to me, I'm like, what is the role of Apollo in kind of that ADHD, that focus? Because when I use the Apollo, it's a way for me to be like, wunk, to kind of like get back into my body, get back into my mind, and not be distracted by what else is going on out there, and really like focus on what's important in the present moment. It's helped me a lot with mindfulness and just like bringing myself back. So to me, I'm like, oh my
same.
gosh, you have to do an ADHD midlife Apollo study.
Yeah, that's actually a really interesting idea. We've done some early studies in kids with ADHD, which has been helpful, but there is this newly discovered sort of in psychiatry, right? This late onset, adult onset ADHD, where we're now discovering that many adults are feeling hyperactive, restless, distracted, having a hard time focusing, hard time regulating emotions. And it's very much looks like ADD or ADHD, but it's showing up more in adulthood. And I think, it's interesting to see all the different factors that contribute to that, stress being a big one. And Apollo is really helpful to help manage stress and improve that sense of present calmness in the body, which is why breathing works and why meditation, mindfulness, and yoga work to also help with menopausal symptoms, is
Mm-hmm.
because they
Yep.
help center our minds back into our bodies. Right. And
Yep.
when we feel more present in our bodies, we're able to actually just listen to what's going on and not judge it or not label it, and not start to make a bunch of assumptions that we're dying because we're going through a life transition, but that our bodies are just going through a life transition. And I was talking to one of the most interesting, I love studying indigenous medicine and Eastern cultures. And one of the things that was so interesting to me about an interview I did recently with Kim Anami was learning from her experiences with studying the way that certain indigenous cultures in South America and actually look at menopause. And what is menopause to them is a time where the woman's body is coming out of a generative phase, where reproduction, where it's geared up to produce new life, this miraculous thing that it's able to do that nothing other than the woman's body can do. And that's a very like expressive, generative, creating, productive phase. And then when entering into menopause, some of the tribal cultures look at it as actually a phase of life where the woman's body no longer is required to generate or produce. It's about taking in and listening and sort of receiving more than it is outputting. And I thought that was really interesting because what they see as the woman's body's role to receive is to receive spirituality, divinity, connection to itself, like holiness, basically. And that is a sacred transition, not what we call it in our lives, which is, oh, you're no longer productive reproductively as a woman in society, then you're no longer you are like a second class citizen now. And that doesn't make any sense.
Yeah.
And that's why the labels are so crazy, and why we have to question them, because the labels dictate how we think about all these things. And so taking into account the spiritual nature, where the yoga, the mindfulness, the breathing, and these natural techniques align with some of these, ancient traditions from cultures that have existed much longer than Western medicine and science, actually have a lot to teach us about maybe there's something else going on in the woman's body and mind and spirit when she's transitioning from one phase of life to another that is actually really great. And it's actually something that we should value more than we look at it as something that we should, scorn or be upset about.
Yeah. Oh, I love it. I love it. I love it a million.
And I think I really want to be respectful of your time. So thank you so much for joining us. I think that's a great place to end. And I'm sure we'll have lots of other questions that come in that we didn't get a chance to answer, but we got through a lot. And I certainly learned a lot. So I really appreciate your time and always enjoy our conversations. And so thank you so much for joining us, first off. And secondly, would you mind just leaving everybody with where they can find you and anything you want people to look for to follow up to answer any other questions they might not have gotten answers to on this interview?
So the podcast is the long form for sex ed and hormones. Lots of good stuff on midlife there. That's called You Are Not Broken. For questions, I tend, again, not individualized medical questions, but Instagram is, I like to hang out on Instagram and I'll answer people's questions in reels on there because it's super fun. And then I practice medicine in Washington State. I'll be opening up a specific hormone sex med clinic probably end of this year for some really individualized deep diving for people. So a little micro practice, which I'm looking forward to.
That sounds amazing. Well, keep a lookout for that, everyone, and follow Dr. Kelly Casperson. Check out her podcast. It is really awesome. And you'll learn so much. If you learn anything today, you'll learn even more when you check out her show. And just really appreciate your time. And thanks so much for joining us.
Thanks for having me.
Bye, everyone. Have a good week.